Greetings, welcome back to ERMP and Beyond, the pulse of clinical medicine. Join the channel as we tackle real-world medical cases, enhance our knowledge, and refine our skills with evidence-based practices. Get ready to unravel today's medical mystery with us. So, without any delay, let's dive into the depths of today's medical case discussion. A 65-year-old male known type 2 diabetes patient taking metformin 500 mg POBID, came for regular follow-up. His random blood sugar is sometimes above the target range. He inquired for a drug that has benefit for both glucose control and prevention of cardiovascular event. For this purpose, the sodium glucose cotransporter 2 inhibitor drug, canagliflozin, was prescribed. What is the complication associated with this drug? A. Hypoglycemia. B. Urinary tract infections. C. Weight gain. D. Hypokalemia. Managing type 2 diabetes effectively is crucial, as it revolves around maintaining blood glucose levels within a normal range. Traditionally, treatments have aimed at increasing insulin availability, either by direct administration or by stimulating the body to produce more insulin. Other strategies include enhancing insulin sensitivity or slowing down the absorption of carbohydrates from our diets. However, a newer class of medications, the SGLT2 inhibitors, takes a different approach by targeting the kidney's ability to reabsorb glucose. Here's how it works. Our kidneys filter glucose out of the bloodstream and typically reabsorb it back into the body. SGLT2 is a protein that plays a key role in this process, reclaiming about 90% of the glucose filtered by the kidneys. By inhibiting this protein, SGLT2 inhibitors allow more glucose to be excreted through urine, thus lowering blood sugar levels in individuals with type 2 diabetes. What's remarkable about SGLT2 inhibitors is that they achieve this without significantly increasing the risk of hypoglycemia, which is a common concern with other diabetes therapies. Moreover, they have the added benefits of reducing both blood pressure and body weight, which are often areas of concern for those managing diabetes. Now, SGLT2 inhibitors aren't typically the first line of defense for most patients. However, they've shown significant benefits for those with cardiovascular or kidney issues. So, in these cases, combining an SGLT2 inhibitor with metformin or another oral agent can be quite effective. Moving on to atherosclerotic cardiovascular disease, it's crucial to choose the right SGLT2 inhibitor. Empagliflozin is often recommended based on its impressive performance in clinical trials, particularly for its cardiovascular outcomes. While canagliflozin also has cardiovascular advantages, it's associated with a higher risk of lower limb amputations and fractures, risks not seen with empagliflozin or dapagliflozin. Speaking of dapagliflozin, although it didn't show a significant impact on atherosclerotic cardiovascular morbidity or mortality in its primary analysis, a sub-analysis revealed a reduction in cardiovascular outcomes. Orforgliflozin, on the other hand, didn't outperform the placebo in reducing the primary composite cardiovascular endpoint. And as for dapagliflozin, we're still waiting on the results from its cardiovascular trials. The impact of SGLT2 inhibitors on patients with type 2 diabetes, particularly those suffering from heart failure or kidney disease, have been a beacon of hope, showing positive effects across the board. However, the decision on which specific inhibitor to use is not one-size-fits-all. It's influenced by several factors, including the healthcare provider's preference, insurance policies, the patient's kidney function, and, of course, the cost considerations. Now, for those who do not have cardiovascular or kidney disease, the role of SGLT2 inhibitors is still significant. They emerge as a potential second or third line of treatment, especially for those who face contraindications with glucagon-like peptide-1 agonist-based therapies. For patients concerned about weight gain from increased insulin doses, or for those who are either unable or unwilling to take insulin, these inhibitors are a viable option. They are also particularly beneficial for older adults who are at a higher risk of hypoglycemia, and for any patient who prioritizes avoiding weight gain. Here again, the choice of the specific SGLT2 inhibitor is often swayed by the cost and the preferences of the insurance provider. We are still on the therapeutic applications of SGLT2 inhibitors. Let's start with patients who have atherosclerotic cardiovascular disease and are not achieving their glycemic targets with metformin and lifestyle changes. In such cases, empagliflozin, canagliflozin, and dapagliflozin have shown to be beneficial, although orforgliflozin has not been recommended for this purpose. Moving on to heart failure patients who also struggle to meet glycemic goals with metformin and lifestyle adjustments, all 4 drugs, including orforgliflozin, can be considered. Another important use of these inhibitors is to slow down the decline in kidney function, specifically in patients with an estimated GFR less than 90 ml per minute. Here, canagliflozin, dapagliflozin, empagliflozin, and orforgliflozin can make a significant difference. Now, if a patient is not achieving glycemic control with 2 oral agents, such as metformin and sulfonylurea, and a combination of metformin and insulin is not an option, SGLT2 inhibitors can be introduced as a third-line agent. Similarly, for those on metformin and insulin therapy who cannot use glucagon-like peptide-1 receptor agonists, and want to avoid weight gain associated with increased insulin doses, these inhibitors offer an alternative. Lastly, for patients who are not adequately controlled on metformin alone and are either unwilling or unable to use injectable therapy, and where weight gain or hypoglycemia is a concern, SGLT2 inhibitors can be used as a second-line treatment option. It's important to note that the drugs I've mentioned have demonstrated significant benefits in clinical trials. However, the effects of begliflozin are still being evaluated, and we're awaiting the results of ongoing trials to understand its full potential. It's important to understand that while these medications can be highly effective, they are not suitable for everyone. For instance, if a patient have type 1 diabetes, or if the patient have type 2 diabetes with a significantly reduced estimated GFR, specifically less than 45 ml per minute for orforgliflozin, or less than 30 ml per minute for empagliflozin, canagliflozin, dapagliflozin, and begliflozin, then SGLT2 inhibitors are not recommended for this patient. Additionally, if the patient have had diabetic ketoacidosis in the past, these medications should be avoided. SGLT2 inhibitors have been linked to certain conditions, and therefore, it's advisable against their use in patients with a history of diabetic ketoacidosis. We also recommend caution when prescribing them to patients who frequently experience bacterial urinary tract infections or genitourinary fungal infections. Those with low bone density or a high risk for falls and fractures, as well as individuals with foot ulceration or factors that predispose them to diabetic ketoacidosis, such as pancreatic insufficiency, substance abuse disorders, or adherence to ketogenic diets, should also be careful, due to the increased risks associated with these drugs. Moving on to adverse effects, the most common ones you might encounter with SGLT2 inhibitors include vulvovaginal candidal infections and hypotension. But that's not all. There have been reports of acute kidney injury, urinary tract infections, necrotizing fasciitis of the perineum, euglycemic diabetic ketoacidosis, an increased risk of lower extremity amputation, and bone fractures. Furthermore, it's worth noting that SGLT2 inhibitor use has been associated with false positive results for ethanol in urine toxicology tests, which is presumably a consequence of glucosuria with microbial catabolism of glucose. So, as you can see, while SGLT2 inhibitors can be a powerful tool in the management of hyperglycemia, they must be used with a clear understanding of the contraindications, precautions, and potential adverse effects. It's all about ensuring the safety and well-being of the patient while striving to achieve the best possible outcomes in the management of diabetes. I hope this information serves you well in your practice and helps you make informed decisions for your patients. These medications can cause a decrease in blood pressure due to an osmotic diuresis and a reduction in the volume of blood within your vessels. This is particularly important for older individuals or those who are already on blood pressure medications like diuretics, ACE inhibitors, or ARBs. If you're starting on an SGLT2 inhibitor, it's crucial to monitor the blood pressure and watch out for symptoms like dizziness when standing up, as these could be signs of hypotension. Next, we need to be aware of the risk of acute kidney injury. There have been reports of patients needing hospitalization and even dialysis after taking drugs like canagliflozin or dapagliflozin. Therefore, assessing kidney function before starting and regularly during treatment is essential. These drugs should be used cautiously, especially if you have conditions like heart failure or are prone to dehydration, as well as if you're taking other medications that could affect your kidneys. There's evidence to suggest that SGLT2 inhibitors might contribute to skeletal fragility, particularly in older adults who may experience fractures after just 12 weeks of treatment. The mechanism could involve a drop in blood pressure leading to falls, or changes in bone density due to alterations in phosphate metabolism. Interestingly, studies have shown that DKA can occur even when blood sugar levels are not significantly elevated, a condition known as euglycemic DKA. This can be particularly tricky because both patients and healthcare providers may not immediately recognize the problem due to the absence of high blood sugar. Therefore, it's crucial to check serum ketone levels in patients experiencing symptoms like nausea, vomiting, or general malaise while on SGLT2 inhibitors. It's also important for patients to stop taking the medication until these symptoms are resolved and to discontinue use altogether if acidosis is confirmed. Another serious concern is the risk of amputations. When compared to other diabetes treatments, SGLT2 inhibitors, and canagliflozin in particular, have been linked to a higher chance of needing an amputation. This risk necessitates extra caution when prescribing these medications to patients who are already at risk for foot amputations. This includes those with severe neuropathy, or loss of protective sensation, as well as those with foot deformities, vascular disease, or a history of foot ulcers. It's imperative that patients on these medications are closely monitored for any signs of foot ulceration. Monitoring our patient is essential when starting SGLT2 inhibitor therapy. It's essential to assess both volume status and kidney function, which includes serum creatinine and an estimation of the glomerular filtration rate before initiating treatment and periodically after that. For those with an estimated GFR over 60 ml per minute, it's recommended to measure serum creatinine after 3 months and then annually, or more often if clinically necessary. If the estimated GFR is between 30 and 60 ml per minute, serum creatinine should be checked every 3 months or as needed. Now, it's not uncommon to observe a short-term decrease in estimated GFR, sometimes up to 30%, after starting on an SGLT2 inhibitor. This is thought to be due to a reduction in glomerular pressure. After this initial decline, we typically see the estimated GFR stabilize. However, if there's a significant initial reduction, it's crucial to stop the SGLT2 inhibitor therapy and investigate any potential causes of acute kidney injury. Moving on to glycemic indices, for patients who are taking insulin or insulin secretagogues, there's an increased risk of hypoglycemia with SGLT2 inhibitors. To manage this, hemoglobin A1c levels should initially be measured every 3 months until the glycemic goals are met. Once these goals are achieved, hemoglobin A1c should be checked at least twice a year, although more frequent assessments may be necessary if there's a change in therapy or if the goals are not being met. Another important aspect to consider is the risk of infection. Patients on SGLT2 inhibitors need to be monitored for signs of genitourinary tract infections and foot ulceration. If a patient experiences frequent bacterial urinary tract infections or genitourinary fungal infections, it may be necessary to discontinue the therapy. Lastly, let's touch on diabetic ketoacidosis. SGLT2 inhibitors can increase the risk of DKA. So it's advisable to withhold these inhibitors during episodes of acute illness, prolonged fasting, or surgical procedures. During such times, An alternative glycemic management plan should be in place until the risk of acute kidney injury, organ hypoperfusion, and acidosis has passed. In the presented case, a 65-year-old male with type 2 diabetes mellitus is being treated with metformin, and has been prescribed canagliflozin to aid in glucose control and provide cardiovascular protection. As discussed earlier, canagliflozin is a sodium glucose cotransporter 2 inhibitor, a class of medications that are known to lower blood sugar by causing the kidneys to remove sugar from the body through the urine. Option A. While hypoglycemia can be a side effect of diabetes medications, SGLT2 inhibitors like canagliflozin are less likely to cause hypoglycemia when used alone because they do not stimulate insulin secretion. Therefore, while possible, hypoglycemia is not the most common complication associated with canagliflozin. Option B, urinary tract infections, are indeed a recognized complication of canagliflozin. The mechanism by which SGLT2 inhibitors can increase the risk of urinary tract infection is related to the increased glucose in the urine, which can promote the growth of bacteria and lead to infections. Therefore, UTIs are a plausible complication for this patient on canagliflozin. Option C, weight gain, is typically not associated with canagliflozin. In fact, SGLT2 inhibitors often lead to weight loss due to the caloric loss associated with glucose excretion in the urine. Thus, weight gain is an unlikely complication of canagliflozin. Option D, hypokalemia is not commonly associated with canagliflozin. While some diabetes medications can cause hypokalemia, particularly when combined with other drugs, canagliflozin is not known to have this effect as a common side effect. In conclusion, the most likely complication associated with canagliflozin in this scenario is urinary tract infections, mentioned in option B. This is due to the increased amount of glucose in the urine, which can serve as a breeding ground for bacteria, leading to UTIs. It is important for patients on canagliflozin to be aware of this risk and to monitor for symptoms of urinary tract infections. It's been a pleasure sharing insights on the SGLT2 inhibitors with you. Your understanding is my top priority, and I trust this session has broadened your knowledge. Don't miss out on future discussions by subscribing. Your feedback is invaluable. Please like, comment, and share your thoughts on how to further enrich your learning experience. Together, let's continue this journey of discovery and improvement. Thank you for engaging with today's content.